We have is Dr. Devesh Kumawat. He will be giving us tips on OCT. He's a graduate, postgraduate and senior resident from RPC AIMS, presently assistant professor in RPC AIMS Delhi.
Thank you, sir, for a kind introduction. So, optical coherence tomography is basically an optical biopsy of the tissues, and it is performed using the principle of low coherence interferometry, wherein you have a light source which is splitted by a beam splitter, and one beam will go to the reference tissue. One beam will be the reference beam, it will go to the reference and it will reflect back, and the other beam will go into the patient's eye through the optical system, and the reflected beams are then detected and analyzed by the OCT software. Now, multiple A scans are combined to give you a two-dimensional image, that is a B scan. So you have a B scan which is in the XY longitudinal plane, and in the coronal plane, if you see, it is the en-face image or it is the coronal scan, that is the C scan. So we have A scan, B scan and C scan. A scan is at a particular point, and you have, if you have a conglomerate of multiple A scan points, then you get a B scan image, and then the B scan image is a cross-sectional, will provide you a cross-sectional image, whereas a C scan image is in the vertical plane, that is in the coronal plane. So there are different domains of OCT which are available. Nowadays we are using the spectral domain or the swept source OCT domains, and the swept source OCT uses a higher wavelength of swept source tunable laser, and it penetrates deeper, provides a better scanning speed and a better resolution. But somehow the time domain has gone obsolete nowadays, and in the spectral domain we also have an enhanced depth mode which provides you a deeper penetration into the choroidal tissues and may be equally good as the swept source imaging. Now these are the images of the time domain, spectral domain and swept source. Now the swept source image, if you can see clearly, the resolution is slightly better than the spectral domain, the penetration is better, but if we see the spectral domain in enhanced depth imaging mode as well, then also we can delineate the sclerochoroidal junction. Now there are different protocols that you should be aware of. Some will cater to the anterior segment, some for the glaucoma purpose, and some for the retinal. So predominantly I'll be talking about the posterior segment retinal assessment. Just touching upon the anterior segment protocols, you have a high definition cornea protocol in which you can have high density cross-sectional images of the cornea at the desired area. You have a raster scan and you can pick up any abnormality in the different layers of the cornea. Then you have wide angle to angle scan in which you can have details of the anterior chamber depth, and you can use this in refractive surgeries, phakic surgeries to measure the lens vault as well. And then you have the angle assessment wherein you can have different parameters of the angle, anterior chamber angle pertaining to glaucoma patient, assessment of glaucoma patients. Then you have the pachymetry mapping as well, in which you can have a pachymetry map at different areas. You can have the corneal thickness. Now coming to the macular scanning protocols, so you commonly have the macular cube or the macular thickness map, in which you get a volumetric assessment of the macula. Then you have a line scan. It can be a radial 1-line scan or a 2-line or 6-line or 24-line, and you can have more denser scans as well. Similarly, you have raster line scans, which will be in a particular orientation, maybe horizontal or maybe vertical, and again the number of lines can vary in that. So coming to the macular cube scan, you generally perform this scan when you want a volumetric assessment. You want to assess what is the central macular thickness or what is the thickness in the outer zones. So you can have a ETDRS grid displayed on top of the infrared image, and you can have the values in the central 1 mm part or the central 3 mm part or the 3 to 6 mm part, and you can quantitate the retinal thickness as well as the edema which is present in the intraretinal space or the subretinal space. Coming to the radial line scan. So radial line scan and raster line scan are basically used when you want to know the details of the morphological abnormality which is there in the macula. And next you have the optic nerve and the RNFL scanning protocol, in which you get all the structural parameters about the optic nerve size and the optic nerve and the neuroretinal rim and the retinal nerve fiber layers. So coming to the tips, certain tips in acquisition that you should know when you are acquiring an OCT imaging. then you should know what scanning protocol you have to choose. So you should be aware that if I want to assess the macular thickness, if it's a diabetic patient, then I need to get a macular thickness cube and not the line scan or the radial line scan or the raster line scans. So you should know what scanning protocol is to be chosen, and you should know the right density of the scans, whether you need a very denser scan or a wider scan. That also needs to be taken care of. So suppose if we see this image, this is a 6 radial line scan, and if there is any abnormality which lies in between these line scans, then that could be missed. If there is a small PD, small CNV which is there in between the two lines, neighboring line scans, then those abnormalities can be missed. So you might need a denser line scan if there is an abnormality in between these. Again, this is a dense 5-line raster scan, and if there is any abnormality in the center of the fovea, then you will be able to pick. But if there is any extrafoveal, parafoveal or extrafoveal area abnormality, then it may be missed on this scan. Now again, this is a scan with greater spacing in between. There are 3 raster lines which are visible, but if we see the central hyperreflective abnormality which is seen on infrared, it will be completely missed on the OCT image. And then you have to choose the area of interest. So if your area of interest is the optic nerve head, or suppose in this picture we can see there is an optic disc pit, and you perform a macular OCT, then you are going to miss it definitely. So you can move your point of interest, that is your fixation target, to the optic nerve head and bring it in the center of the image, therefore choosing the right area of interest. Now to interpret, you should first check the patient identity, whether it is the same patient that you are looking at, the eye, the right or the left, and the date, whether it is the same day you want to assess the image, or is it the previous or the follow-up image. Whether the scan is reliable, you should look at the strength, that if it is 6 or 7, more than 6 or 6 out of 10, then it is a reliable scan. And then the area of interest, you can look in the infrared image available to you. Then read the scan in a systematic manner, that you should first go through the vitreous, if there are any abnormalities in the vitreous, any membranes or any cells, and then there is abnormality in the vitreoretinal interface, any membrane or any traction at the macula, then the intraretinal pathologies, then come to the Brooks RP membrane, then the choroid and the sclerochoroidal junction. Now quickly, this is a swept source imaging which is there, and it clearly tells you the anatomical landmarks in the normal posterior segment, wherein all the nuclear layers will be hypo and all the plexiform layers will be hyper, and even your retinal nerve fiber layer and the ellipsoid zone and RP Brooks membrane are hyper. Now, in the interest of time, I would like to skip the examples and come to certain important things here. Like for diabetic macular edema, if you want to quantitate the macular edema, go to a macular thickness cube or a macular thickness map. And if you want to see abnormalities such as CNVM or tractional maculopathy, then you have to go to your line scan or the raster line scans. Now, a bit about the other advances that we have NFAS OCT also. NFAS OCT will provide you image in the coronal plane. So you use this modality predominantly when you want to know the progression of the disease in the coronal plane, such as in geographic atrophy progression. You can very well delineate the areas of atrophy on the C scan image, and also if you want to see how much is the circumferential extent of the edema, whether it is central involving or it is going in the periphery as well, in the peripheral part, peri and parafoveal areas, then also it is helpful. Next, you can have the wide field OCT which has come up, and you can easily image the peripheral treatable lesions and then come to know whether any retinal breaks are there or retinoschisis is there. So you can easily make out using your wide field OCT. Last, you have the intraoperative microscope integrated OCT, which is very helpful in the corneal lamellar surgeries as well as in the macular surface procedures. To summarize, OCT is a fast, non-invasive tool, and it can be used to section any part of the ocular tissue nowadays, and it should be interpreted in a very systematic fashion. You should focus on the scanning protocol which is used and the imaging quality. It should always be interpreted in correlation with the fundus picture, never alone. And with the technological advancement, you are getting newer and newer types of OCT modalities that are coming up, that is helping us in better understanding of the ocular diseases. Thank you.
Thank you, Devesh. Any question? Right. So, just one point, especially the glaucoma module. I mean, deciphering the deficiency, the defect in the glaucoma module, especially the RNFL defect, and all, that is all color coded, right? And you get a graphic representation as well. So from those things you can make out whether it is green, yellow, red, as per that, whether there is a defect or not. So by simply just looking at the color coded map, one can make out whether there is a deficit in the RNFL this thing or not.
Same goes for the macular thickness.
Yeah, same goes for the macular thickness also.